We've got a stellar collection of panelists with us. It's quite an exciting event because it's only the second larger scale virtual conference that we've run on this platform. So we're all still getting used to it. But it's a very important topic that we're going to be discussing today. I have recorded video interviews with all of the panelists that you see on the screen now. They're all experts in different aspects of this first panel discussion session: digital diagnostics, response planning, and patient monitoring, etc. Chris, so you are the CEO and founder of Spirit Healthcare Group. We did a video recording earlier this week on the kind of work that you're doing. So would you like to just say a little bit about the Clinitouch product and its relevance in digital diagnostics?
Yeah, so Clinitouch is largely for remote monitoring of people with long-term conditions. It's been used in the NHS in various guises for nearly 10 years, but much more recently with the ongoing virus situation, it's been used rapidly and at scale. So Clinitouch is the ability for people to remote monitor patients with structured question sets, intelligent algorithms in the background, and the chance for clinicians then to receive a triaged dashboard of patients and tasks that require completing to help scale up their ability to manage more people at the same time. So we're increasing the capacity in particularly intermediate care and long-term conditions teams for COPD, for heart failure, to help free up space for people being discharged from hospital with COVID-19.
So you described this in the video that we recorded as a virtual community ward, am I right? So is that the sort of analogy that you would use for this?
Yeah, so I find it quite difficult, David, to articulate whilst talking about it without showing what it looks like. So for anyone that wants to, I'm happy to show it because it's easier to visualize. But it's the ability for you to do pretty much whatever you would do with a patient on an actual ward, but remotely. Obviously, the one thing you can't do is touch them. So you can video conference, you can text message, you can do vital signs monitoring of their clinical parameters, you can ask them questions, you can watch videos, you can educate them. So all of that's possible, but without physically touching a patient, which at times like this is quite useful.
Okay. So your slide presentation is titled Virtual Community Wards, and it's about a product that you've got called Clinitouch V. So just tell me a little bit about the background to these health-related challenges.
Yeah, so Clinitouch was, as I said, conceived back in 2010 and has been used in the NHS across that time. It's also a published evidence base of how it works. If I look at the challenges that it tried to overcome in normal times prior to COVID-19, then essentially we had a growing demand for services. So we needed to find ways to stretch our existing healthcare resources further. We also had increase in hospital demands, which we wanted to reduce. And if you look at most healthcare services and how they work, they tend to be quite reactive, i.e. someone gets poorly and something is done unto them. So what we wanted to do was find a way to be more proactive in that healthcare arena and try and find ways to be presenting patients who were not yet poorly.
Okay, so Clinitouch is designed to address those by connecting patients in their home or care settings with clinicians and help to address some of the problems that you've identified. So this is the screen that people will see on their Clinitouch platform. So this is presumably a kind of iPad application?
Yeah, so Clinitouch is a bit of software that can be downloaded onto any device that someone has, David. So you can use it on your own phone or a tablet. If people don't have access to that technology, and at the moment with COVID, we're deploying hundreds and hundreds and hundreds of tablets into the NHS to help support people who are self-isolating. And then this is the home screen that someone would see.
Yeah, okay. So it performs a variety of tasks. So we're talking about here a concept of a virtual ward, which is recording patients' vital signs, and it's using artificial intelligence and algorithms to be able to assess risk. Is that correct?
Yes, that's correct. So in effect, a patient can create some data from questions, from from vital signs. That gets sent into a database that risk scores that using algorithms, and then clinicians are pushed that data in real time, so they can prioritize on an ongoing basis the caseloads that they're managing, so that they can focus on the most needy at any given moment in time.
Yeah. So looking at the infrastructure behind CliniTouch, you've got a patient app, and I understand that you get various devices that will connect to that. What kind of devices are you currently connecting to CliniTouch?
So there is quite a long list. So everything from blood pressure machines, blood oxygen saturation monitors, scales, atrial fibrillation devices, respiratory rate monitors. I can't say sphygmomanometers very well, but there we go. So yeah, the list of devices that we can put in there is pretty much unlimited, David. As long as there is a Bluetooth connection, we can Bluetooth into the system.
Okay, and so some of these devices, like wearable devices, will be consumer type devices. Presumably others will be medical grade devices.
Yeah, correct. So in this current climate, getting access to devices is hard. So if people have their own devices, then we have also made it possible for people to use their own devices to input data into the system with COVID-19.
Okay, so it's a little bit along the lines of personalised medicine, really. As you're saying, it's you're able to configure it to individual patients' needs.
Yeah, so the system is typically deployed by NHS clinicians, and it's typically deployed into cohorts of individuals. So if I look at a current deployment we're working on at the moment, it's largely focusing on people with respiratory disease and heart failure. And in that, you can then tailor the questions so that people only get asked questions and present data that's relevant to them and their condition at any given time.
Okay, so in essence, it's really reducing the load on hospitals by enabling safe remote care. Is that in a nutshell?
So yes, I think there's one other thing as well, which is that it supports self-isolation. So this is about people who are at risk, who are really some of the most vulnerable in society, be they on a case management list from a long-term conditions nurse, or be they sat in a care home or a nursing home. We can remotely monitor them, we can keep them safe, and we can have clinicians interacting without any physical contact.
Yeah, and I guess this is very important in today's climate with COVID-19. And some of the research results seem to be quite impressive, particularly with the savings in hospital admissions, but clinical outcomes also very important.
Yeah, so we can demonstrate with published results that we've got a reduction of 67%, so 2/3 in unplanned emergency admissions to hospital in COPD, so respiratory disease. We can also show that we do that whilst increasing the productivity, so the number of patients that each chronic conditions nurse can manage, whilst improving patient outcomes. So literally across the board, it meets the demand.
It sounds like a no-brainer, really, but at the end of the day, I guess the bottom line is the patient experience and the fact that you're able to save lives.
Yeah, I mean, so this is a piece of technology which is actually, it's been developed so it's simple, so that patients and individuals and people and our relatives can use it, and it's there to support them and keep them safe and well at this time.
So it's pretty much a win-win relationship between the medical profession and the patient cohorts. And prior to COVID-19, you seem to have specialised particularly on chronic health conditions, which normally would be at risk for hospital admissions. Is that right? Yeah,
correct.
Okay, so here are the details shown on the screen there for anybody who wants to follow up with you.
Yeah, so like I said before, it's a piece of software that can go into a patient's house that then connects them to individual clinicians that are monitoring their care as part of a caseload. That's how it's currently been deployed in the NHS, and that's how it's been used.
So with the coronavirus, what's your experience of this platform in the current coronavirus situation?
Yeah, so two separate things actually. One is that there are lots of people currently in hospital who are being asked to get out very quickly, and potentially some people that wouldn't have been asked to depart hospital if they weren't for the virus situation. So we are supporting that discharge with providing equipment so that they can carry on having monitoring whilst in the community in that virtual ward situation. So that's one thing. The second is that to free up capacity of nurse teams, which are already constrained by people being off and being deployed elsewhere in the virus, we're deploying the exact same technology to patients' houses in normal managed cohorts of patients, so normal caseloads. And that's meaning that your average caseload for a long-term conditions nurse is going from 50 to over 100 patients. But we can demonstrate from previous evidence that we can do that without harming care, so we can do that whilst maintaining or improving care at the same time. So yeah, it's been a leap forward in how the technology has been used. Instead of being deployed to tens of really poorly patients, it's been deployed to thousands of people.
Okay, so that's that aspect of it. But from the patient perspective and keeping people out of hospital, how is that working?
So from a patient perspective, we have had comments like, it's reassuring, it's comfortable, it's nice to have someone still checking on me. Yeah, there have been edicts in certain conditions that people should have their care to some extent suspended. So what we're able to do with this technology is give patients the reassurance that they're still being looked after, they're still being case managed, they're still getting themselves feedback on their condition, whilst also being connected to a clinician who can triage the most poorly patients for action. So patients are liking it, they're having some equipment in their house, either through their own device or a physical piece of equipment, and that's helping to support them to better manage themselves whilst also being checked on by clinicians.
Yeah, so it does have some intelligence and some education features for the patient. So you're using artificial intelligence to provide advice to patients to help them to manage their own situation.
So there is branching out and some intelligence in the background, which then helps direct patients on the right things to do based upon their responses.
Okay, thanks for that, Chris. Now I'll bring in Leon because your product Oxytone is very much related to this situation, isn't it?
Yeah, it is. Actually, overnight we became celebrity in the United States. I don't know, we do not sell it in the UK yet. But our product was designed specifically to remotely monitor high-risk patients with fibrosis, COPD patients actually. And today, fibrosis is caused by COVID-19. So our platform exactly dedicated for patient COVID with all questionnaires, symptoms, and monitoring capabilities. It includes world first FDA cleared and the CE certified pulse oximetry monitor at wrist. There is no any fingertip sensor. So this enables to monitor patients out of the hospital 24/7 on the same level like hospital grade oximeter. So actually it's just extension of ICU or hospital grade care to home. So we start to receive a lot of orders from United States, from hospitals, which are in front of battle with COVID-19. So with our product, hospital physician just give our product to patient, get connected patient to his dashboard and send home with continuous SpO2, it means blood oxygen saturation measurements. And blood oxygen saturation today is the most important key vital sign for COVID patients, monitoring and assessment and screening. So actually, this is a full platform that enables patient monitoring at home. One interesting example of deployment, even we didn't expect such challenges. We wasn't ready for these challenges. We deployed our product in one of their nursing homes. And it was very interesting experience because out of 100 elderly patients there, it was about 10 patients tested positive for COVID. And they also, all nursing home was locked together with 3 or 4 nurses there. And we successfully deployed our devices and our product with these COVID patients. They are between 80 and 90 years old, so very, very risky. And we succeeded to convince the staff who is locked there as well to pay attention to these patients, to charge devices, to connect devices, charge once a day. And actually, data started flow from the house, from the nursing home, which was before totally locked, and nobody did know what happened there.
Okay, so it allows you to do remote monitoring, and we talked about situations for patients being at home, but this is a care home setting where you've got a lot of patients in the same environment, but you're able to effectively monitor the situation outside of the hospital with the data that you are collecting. And your device is a wrist-based device, which is one of the innovations. Instead of having something to wear on your finger for a pulse oximeter, it's a wrist-based device which monitors a number of different things. There has been a question from David Calder, and he's asking, is the present system, and I guess this applies to both of you, for primary or secondary care? What he's suggesting is that for coronavirus is more around discharge or secondary care. So, Chris, do you want to make any comments about that question?
Microphone back on.
Yeah.
So the answer is both. So CliniTouch has been deployed into larger intermediate care settings. So that space between primary care and secondary care where you have specialist case management. We've also got care homes that have been used by GPs in the UK. So with the advent of PCNs and the new care home DES, direct enhanced service, that's coming out, there's a lot of interest from GPs in managing care homes differently. So it's been deployed in that setting. And then we're also having some discussions in India currently where they're experimenting with deploying this via insurance companies as well to individuals. So the answer is both. Both.
Okay, Leon, you want to make any comment about that question?
Actually, our customers just B2B, just organizations and providers. We do not sell devices and product to consumers because it's a full platform. So it should be admin, should be some physician to monitor all these patients. And we say that we unlock patient intelligent data just in one click. So just in one click, physician could monitor 1,000 patients on one page and get inside the data like in hospital exactly. Even the screen of monitor on the desktop computer looks like this, like screen from the hospital. So it's a full extension of hospital care to home, and it looks like it's a technology of tomorrow.
Yeah.
And what's interesting, I would like to add that some companies and hospitals apply to us because we have a huge readmission. So people released from the hospital after they just get out of COVID, and in 4 days they get back again with COVID. So this is very tough problem, and it looks like our product enables to catch up in time with the situation and understand better what happened with these patients.
Okay, thanks very much for that, guys. I'm sorry Steve wasn't able to join us. I just say 1 or 2 words about what I discussed with Steve, and I refer you to Steve's YouTube video. If you need a link to that, just please let me know. But Steve's very much involved in big data analytics and genomics and phenomics. And the thing about Steve's work is that instead of a lot of work involved in doing and analyzing the impact of a single genome, it looks at the influence of multiple genomics. So I'm going to close this first session down and just thank you guys for joining it. And we're going to have a 5-minute networking session now before we start the first panel session. Can I draw your attention also, those delegates, of the sponsor tables on the left and the right? Spirit Health, where Spirit Healthcare, I've got one of the tables on the right hand side. So Chris, maybe you can sit there and people can join you and ask you about your work. And Leon, look for Leon and join him at his table. So thanks for that session, guys. We'll be 5 minutes networking and then starting the next panel session.